want to just express our huge gratitude to Jo Tonkin, my colleague from Public Health, who many of you will have met, who has worked across the South East region, who's given up a great deal of her personal time to do this as extra work for us. So we're really grateful to Jo for doing all that she has done to make this possible. So colleagues, welcome. The purpose of today is to really start to think together about equality and diversity of our children and young people and its relevance to emotional well-being and mental health. You'll know from our many conversations together over the last year or 2 or 3 together that this has become increasingly important for us. In our most challenging situations, we are seeing the equality and diversity needs of our children impacting on their emotional health and well-being. And that's not a picture that we've always understood terribly well. This event was designed specifically to enable Jo and other colleagues from Public Health, but this is primarily Jo's work, to share with us what the analysis of our child population can tell us about the range of diverse needs that we need to be able to try and cater for in our strategic design and delivery of children's emotional and mental health services. It's timed so that you've got some core information that you can, one, take back to your local systems leaders, public health colleagues and so forth, and your other colleagues in CCG, local authority, and in our community provider arrangements to say this is our picture of children at top level. This intelligence is designed specifically to then shape the way that we design our emotional and mental health services. And many of you are busy working right now on local transformation planning, yes. And so the timing of this is designed to support you with that needs analysis work, but it does need to lead to action, yeah? So I know many of you are already sort of looking at this area and thinking, how are we going to really do this together? And so this session is intended to enable some time for that. Jo has kindly broken down the content that she's providing us with into 15-minute chunks. So after every 15 minutes, we're going to stop and we're going to take a little bit of time just to reflect and to pose some questions. So it would help us tremendously if, as we go, you can pose your thoughts, reflections and questions in the chat. And then every 15 minutes or so, we'll stop and we'll talk together about those points that are arising. Following this session, one, we have recorded the session, so we'll be able to publish it and share it with colleagues who aren't able to join us today. But 2, we'll also produce a frequently asked questions document. So as you're posing those questions, if we can't cover everything today, we will get back one way or another to you with some responses. I hope that feels helpful to everybody. So without further ado, I'm going to introduce Jo. Jo, you are so welcome, and we are so grateful for your many extra hours doing this work for us. So very much over to you with our thanks. Thank you, Jo. Jo, you're on mute at the moment.
Can you see my screen?
We can see your screen. Thanks, Jo.
Brilliant. So welcome colleagues and welcome friends amongst you in Kent as well. You'll know that I'm the Health and Wellbeing Programme Manager leading on public mental health and vulnerable children and young people across the South East in Public Health England, and I come from a population health perspective, sort of looking at seeking to understand what the patterns of ill health are in the population of children and young people, what groups are most at risk, and what inequalities arise out of access, use, experience and outcomes of service. This is the aim of the session. Its aim, like all of our aim, is to reduce inequalities in mental health including in the prevention, access, utilisation, experience and outcomes of services. This is what I'm going to cover, but I guess just a kind of word of warning. And first, in relation to the language that I'll be using, which largely comes from epidemiology's diagnostic categories, so the language of disorders, which perhaps doesn't feel wildly kind of comfortable. And secondly, I'm presenting data which is really on a kind of sort of southeast level. I've just sort of drawn together data intelligence which comes from large population surveys and administrative data that's systematically collected and publicly available. It's about need and inequalities. It's not so much about kind of the sort of service aspect, and that comes from mental health service data set and from your local service monitoring data. But I just wanted to kind of sort of reference this programme of work, incredibly kind of progressive programme of work. And it starts by asking, you know, who is our population? And I guess in some ways we're going to get closer to understanding that today. I think that there's a great deal of expertise in the room. So some of the tools, evidence and analysis that I present today will be very familiar to you. As Andrea said, the presentation is chunked out into 3 sessions, 15 minutes, hopefully. What I hope I'll be able to do is provide you with a bit of space to think, to ask yourself and others questions. The presentation that I'll deliver today is a short presentation. There is more detailed slides which I can provide you with, and I will also make sure that I answer any question that's presented in the chat, either now or after the presentation. So just in terms of tools, concepts, definitions and sources of data, these are the definitions of inequality, inequity and vulnerability. Health inequalities being differences in health status, so what we're looking for is variation, and vulnerable children, young people are those who we understand as being most at risk. And clearly there is an interaction between those different categories. So this is a useful diagram which kind of talks about how those things overlap. Populations who are vulnerable, like for example those who are with learning disabilities, may also live in the most deprived communities. They are protected by the Equalities Act due to the discrimination they experience, and that we must work hard to protect them against. They may also experience inequalities in relation to geography. Geography alone may be a barrier to those young people accessing protective factors which benefit them as individuals, for their families and their wider communities. And just to kind of remind ourselves that when we're thinking about children's mental health, we're thinking about the impact of risk and protective factors at the level of child, family, school and community. Protective factors or resilience factors at the level have the potential to reduce the impact of cumulative risk and adversity. So just in terms of the tools that are available, a good sort of starting point, I'm sure many of you are familiar with the child health profiles, which are kind of continuously updated. They are available at local authority level. We'll go on to talk about integrated care systems and their kind of footprint. They're available on fingertips. And on fingertips as well, here's the children, young people's mental health and wellbeing profile. You can see a range of different indicators around need, about primary or secondary prevention, and about services. And then for each local authority area, you can produce a sort of spine chart showing what the values are and whether the values are, compared to England, worse, similar or better. I just wanted to draw your attention to the set of resources referred to as No Child Left Behind. These are Public Health England resources which come from a understanding that vulnerable children, young people, are also young people who have experienced multiple adversity, including adverse childhood experiences. So within this suite of resources, you're able to download narrative reports in addition to the national reports, and there's also a data set which is available to you. I also wanted to draw your attention to the HEAT tool. So one of the tools that's used systematically in local government and other public sector organisations are in order to meet the Equality Act is equality impact assessment. And I guess my challenge to you is if you are implementing approaches which seeking to address health inequalities, you need a systematic tool. The HEAT tool is a very straightforward tool available on the Public Health England website, and it enables you to prepare, assess, refine and apply and review. So go through that improvement cycle around inequalities. It is straightforward. There's e-learning that kind of supports its use, and really just ask these two questions: what health inequalities exist in relation to your work? So those are things that I might highlight later on. And how is your work impacting positively and negatively in relation to those inequalities? And, you know, what are you going to do about that? So just other sources of data and intelligence, local health and SHAPE, which provides indicators at lower geographical areas. Of course, much of the fingertips data does not include the impact of COVID, but the WITCH tool and CHIME, which specifically looks at inequalities in relation to COVID, they do, and again, are being constantly updated. There are evidence reviews on addressing health inequalities for children and young people, developed with Public Health England and the Institute for Health Equity. Of course, there is a challenge of administrative boundaries, and much of the data in relation to children in terms of understanding need is collected at a local authority level. Here we are looking at a picture of the South East, and obviously the South East is an enormous geographical area. It's approximately just over 9 million people, 23% of whom are under the age of 25. If you want to look at variation, you need to get to a much lower geographical level. You can therefore look at local health, which I've already referred to, or indeed the SHAPE tool. So SHAPE, so it's actually a very straightforward kind of tool to use. This is a image of the distribution of deprivation in Bob at lower super output area. And this is an example of the a map showing the distribution of this is Asian or Asian British populations across Bob. Brilliant. Has anyone got any questions?
Thank you, Jo. So we've got one first point, and I know you're just kind of walking us into this at the moment, from Deb Hunter at Reading, which is asking about the ecological model of resilience. So she's reflecting on the fact that the more support our children have from significant others and also from a range of support services, the more likely they are to have greater resilience, and also the less likely they are to develop emotional or mental health need that progresses over time. So that's a key reflection from Deb.
Absolutely. And that ecological kind of model is reflected in that risk and protective factors kind of conceptualization. I do think those protective factors align with what we understand about resilience, but absolutely it's that trusted adult that is key.
Thanks so much, Jo. Tim from Hampshire and Isle of Wight has also raised a really helpful point about another tool that the DfE have produced that's a really useful source of information. Tim, thank you for that. So part of what we're doing is saying all of these things are there, and particularly resources like the Fingertips resource you can access at any point. They continue to grow to help inform these conversations.
Yeah, I think Tim might be referring to the Explore Statistics tool, which I use for later on in analysis. So just kind of moving on then, evidence of need and the prevalence and the impact of COVID on children with protected characteristics. So these slides are taken from a presentation, in fact, a toolkit that I developed around a recovery from COVID. Really, in relation to protected characteristics, I'm just looking at age, gender, male, female, disability, and ethnicity. And these are largely the protected characteristics which are reflected not equally, but in most of the kind of data that's available publicly. So just in terms of age and mental ill health, the trend is for mental ill health to increase from school age into late adolescence, and that varies from by different conditions. This finding here is taken from a global study just published, which is identifying the age of first onset of a mental health condition using ICD-11 diagnoses. So you'll see that kind of variation over the age range. If you look here, the vertical axis is providing the median age of onset. But what this study tells us, it's a meta-analysis, is that a third of mental health conditions start before the age of 13. Sorry, a third before the age of 14, and half under the age of 18. 62.5% start under 25. Now that's similar to the findings in the UK that often referred to around 50% under 18 and 75 under the age of 25. The peak age from this study is noted as between 15.5 and 18. Now, why that's important is that if you understand what the median age of onset is, you can also target development prevention interventions at the right developmental period. So really kind of understand what those risk and protective factors are and build protective factors around those key ages. You'll know that NHSD, the survey, population survey, usefully undertook a survey in 2020. So it provides some, not perfect, but some comparison from the previous survey in 2017. So it gives us a sense of what the impact of COVID has been on children and young people. And here we see, as I'm sure you're aware, that rates increased to 1 in 6, 60% of children aged 5 to 16 identified as having a probable mental disorder. increasing from 1 in 9 in 2017, and this increase was evident in both boys and girls. The increase is seen amongst boys in that primary age group. In terms of that older group of young people, we see this increase again in 2020, and this is more pronounced amongst young women, with 27.2% of young women and 13.3% of young men identified as having a probable mental health disorder. And you may well be familiar with this, these slides just showing the sort of distribution of mental disorders amongst boys and girls. So here showing this is data from 2017 NHSD survey, showing that in the primary age we see more boys than girls, and that kind of converts into seeing more girls, a greater percentage of girls than boys in that older age group, 17 to 19. This the figure on the right, this is common mental health conditions reported in the adult psychiatric morbidity study. We see age here on the horizontal axis. Men are blue, women are grey, and we see this extraordinary difference here, showing young women having much higher percentages of common mental health conditions, such that young women were identified as an at-risk group in the adult psychiatric morbidity study, whatever adversity, other protected characteristics they had. Just in relation to eating disorder, you will be kind of aware of the difference between men and women. Here on the left, we see the increase, the peak of eating disorders amongst young women aged 25 to 34. I think overall, what I sort of take from this the health survey for England is actually the very high rates of eating disorders across the population. So generally 16% of adults aged 16 and over screening positive for a possible eating disorder. 4% of those reported feelings that about their food that interfered with their ability to work, meet personal responsibilities, enjoy a social life. The proportion of adults aged 16 or over who screened positive for possible eating disorder increased as household income decreased. So again, we see the social gradient, which is so evident in so much of the mental health epidemiology that we look at. Just in relation to LGBTQ, it's estimated that 2.5% of the general population identifies as LGB, and other. That's how the data was kind of collected using that kind of terminology. So it's a significant minority of our population, clearly a group that we need to think hard about their needs. There isn't a great deal of evidence through surveys of needs, mental health needs amongst this population, but we do generally believe that mental disorders are higher amongst this age group, including depression and suicidality. That group of young people who present as trans, clearly there's again lots of concerns about their emotional mental health, but little data. In relation to children with disabilities, estimated about 8% of the population have a disability. of children have a disability, with a high prevalence of mental ill health and much lower levels of mental well-being. These families are disproportionately more deprived. So in addition to the daily stresses that this results in, they'll also have less access to some protective factors. There is a strong indication that children and young people with disabilities and their families have been disproportionately affected by COVID. And we can see that kind of change over time as lockdowns are put in place and then released. In the CoSpace study, as a longitudinal study. Just thinking about children with autism, around 40% of young people with ASD had at least one comorbid anxiety disorder. And I think if we think about the impact of COVID on social interaction, on routine, we can see that this young people with autism may well have had a particularly bad experience. Just in relation to disability and gender, clearly there is a variation by gender. We tend to see more boys in that early childhood age group. Ethnicity assessment in children's mental health data is generally poor. There's been a sort of historic concern about self-harm amongst Asian young women. The evidence around the disproportionate impact of mental ill health on Black and minority ethnic populations, that research tends to be sort of focused on adults, where we see higher rates of mental health problem, more of those adults seeking help in crisis rather than accessing services earlier on, being admitted to hospital with a mental health problem, experiencing that poor outcome from treatment, and disengaging from mental health services. And I think it's that concern that we see this population overrepresented in that sort of hard end of services that makes us, well, forces us to consider how we are meeting the needs of these population groups kind of earlier on, and how we are overcoming stigma, prejudice and discrimination. Clearly there's a lot of interest at the moment in understanding the disproportionate impact of COVID on Black and minority ethnic groups, and with that a more building and understanding of the impact of racism on mental health. I think the interesting thing about ethnicity is strongly related to poverty. Poverty being twice as high amongst all ethnic minority groups than white British people in the UK. That doesn't impact the same on each ethnic group. Here we see children from Pakistani, Bangladeshi households were more likely to live in low-income households than other minority ethnic groups. Just on the issue of poverty and deprivation isn't a protected characteristic in itself, but it is, as you all know, a significant determinant of mental ill health. And if you don't see children, young people from your most deprived communities in your services, then you should be asking yourselves, why not? We know that children with probable mental health disorders were more likely to live with a parent who was experiencing psychological distress, who overheard their parent being involved in arguments where there were concerns about finances. So, any questions?
Thanks, Jo. There's an awful lot of really kind of important reflections and questions arising in the chat. So it's worth saying that the adverse impact of exclusion, prejudice and mistreatment for those within our community who are experiencing othering in Gerard's terms is very much foremost in all of our thinking, isn't it, across the South East, based on our findings from some of our most significant pieces of analysis work. So it's really important as we think about our community with diverse ethnic and cultural heritage, our rainbow community, and also our LD community, to bear in mind that it's that impact that's informing the emotional and mental health needs that we are seeing. And our services sensitivity to that really does matter. It is much harder to ask for help when that has been your experience, to trust that professionals will hear and understand that. Also arising in chat, Jo, is the kind of concern around eating disorders particularly, and much of our kind of focus on that. If we can turn to some really specific questions, Jo. Is data available, this data available at GP level or PCN level, and could colleagues access that, please?
Some of the data is available at GP practice level. It's not all of the children's data, but I'll contact you directly and show you where you can find that.
Thank you, Jo. That's incredibly helpful. So, colleagues in Frimley, we will get back to you with that. What's the best model or approach for the mental health and well-being of our children with learning disabilities, our autistic cohort, Jo? So, recommendations from research, really.
I'm not sure that I can answer that, but I will endeavour to find out for you what the best evidence is at the moment.
Thank you, Jo. What we'll do, Trish Hagan, will work with colleagues in your service, please, and we'll respond to that question in terms of evidence-based. Thank you, Trish. So we'll respond to that afterwards. There's a specific question around faith groups, Jo, and whether there's any analysis of the interface with faith and belief, and also some reflections about the importance of working with our colleagues leading faith and belief organisations and environments because of this composite inequality that we've talked about. Is there any further data on that we could be drawing on, Jo?
Well, there is broadly an understanding that engagement in faith organisations is protective, and I think that that's included in that conceptualisation at the beginning. But you're right, and your faith is a protected characteristic, but you don't see that routinely collected or reported upon.
Thanks, Jo. And of course, what we've also seen is exclusion from faith and belief networks and forums and communities can have an adverse impact on emotional health and well-being. Tim from Hampshire Isle of Wight's made an excellent point about our recording of the characteristics of our children is often quite limited. How could we improve that? What could we be doing that would help us build this picture and also then respond in our service design? Any thoughts on that, Jo?
Well, I mean, I'm really interested in understanding that as a kind of improvement piece of work. And my understanding is that the programme improving inequality in mental health is sort of designed to do that. But I don't know. I'd kind of come back to you as NHSE kind of commissioners colleagues about how that work is happening. We know that data collection is poor.
Andrew, it's Trish here. I'm just saying I'm working with the SEND colleagues in the region. I'm going to a national meeting soon because what ideally lots of these children, but I'm talking about children with learning disability, autism, etc., will be often known to paediatric services and stuff. So we're having conversations around ensuring that they get identified much earlier through health visiting, those sorts of, making sure they're identified so that they're at least then called for checks and people then will have that information. That'll be probably at primary care level initially, but just to say we're having those conversations.
Thanks so much, Trish. That's really helpful, and it's an embedded part of our conversation from commissioning in provider contract discussion and dialogue to say how can we improve the recording of these characteristics for our children, because it matters. We need to understand this. There is an interagency response around improving our recording of this, specifically around suicide prevention and transformation, for example, which cuts across all of our agencies as a shared priority and shared endeavour. Tim's point, of course, is we must adjust how we offer help and support. Absolutely. Recognising how hard it can be to ask, and recognising the context in which our children will be arriving at the door asking for some help, needing to adapt our offer. There's another question around compound inequality and the impact that could have, the further impact that could have on boys and girls, Jo, and whether there's, I appreciate we've used kind of gendered labels there, and I'm very mindful of our transgender cohort and non-binary cohort as well. But any further thoughts on that in terms of compound inequality, Jo?
Yeah, I mean, you're absolutely right. What this data doesn't do very well, and it is very broad brush, as you'll notice, is it doesn't really address kind of intersectionality and cumulative adversity. But we know some of that through kind of other kinds of research studies, don't we? So yeah, I can't present on that. But that's it's certainly a factor if you're a young woman and a poor young woman, and you have faced other adversity in your life, then your risk of ill health, and hopefully, but potentially, your inequalities in terms of access and use and outcomes of services are going to be less.
Thank you, Jo. That's incredibly helpful for us. I guess the other part of this is that data is just one aspect of our commissioning and service design and transformation picture. Talking to our children matters. Talking to our children with diverse experiences matters. Engaging with our community leaders, our faith leaders, other leaders who will have different relationships of trust helps inform how we can create and design services that respond to the lived experience of our children, particularly at the moment. That's so crucial. One last question, Emanuela from Berkshire West. No, the LGBTQ commissioning guidance has not yet been released, but the LGBTQ plus resource suite of services has been released, and we have shared that with many colleagues, so we can recirculate that with the notes from this webinar. What we might do now, if it's okay, Jo, is move on to your next section, if that's all right, and we'll continue to collate questions as we go.
Brilliant. Yeah. So I'm just going to present back some analysis of vulnerable populations by protected characteristics. Again, really just focusing on age, sex, disability and ethnicity where possible. Some of this data is sort of presented at England level, some at South East level, and some at local authority level. So just in relation to SEND and emotional and those need types, those children, young people with social emotional support need type, 47% of children with SEN requiring statutory assessment are estimated to have a mental health condition. This shows the percentage of pupils with SEN support by local authority 2020-21. Comes from that excellent Department of Education statistics tool. So there's the link below. Those we're comparing to the Southeast, and those marked red, Medway, Reading, Portsmouth, Brighton Hove, West Sussex, Oxfordshire and Southampton have a higher percentage of pupils with SEN. And this is the percentage of pupils with educational healthcare plans in the southeast. Now, local authority colleagues will know that comparing against southeast or England is not always the best. So local authorities will have statistical neighbours, kind of other local authorities which have a similar, perhaps scale population kind of makeup, which perhaps provide a kind of more accurate comparison. This is the fingertips spine, so directly kind of copied from fingertips, showing social, emotional, mental health needs of children, young people with SEND in the primary age group. And again, we see a higher rates amongst some local authority areas there. Southampton, Portsmouth, Isle of Wight, Oxfordshire, Reading, Windsor, Maidenhead, Brighton, Hove, Medway, East Sussex and Kent. And here they are for secondary age children. I'm interested in people's interpretation of this need type. It is sometimes used as an illustration of the prevalence of mental health needs, but in its collection, I think that it is actually talking about quite a small percentage of our SEN population with quite sort of specific kind of needs. So be interested in your thoughts about that. Just in relation to SEN and age, SEN's most prevalent at age 10. This is analysis from England, and it decreases from that age. EHCP plans tend to peak at around 11. You know, it's that kind of transitional moment when children, young people seek, or their parents seek kind of plans in order to ensure that they get the right support in secondary age. And as I've said before, relation to disabilities, prevalence of is greater in boys than in girls. This slide shows SEN by free school meals. So here, this population on the left have no SEN. We've got SEN support and statement of educational need. This group, those with educational healthcare plans or statement, is much smaller. So really what we're just looking at is the comparison between those with no SEN and those with SEN support or an EHCP. And you'll see that those with SEN support or an EHCP are more likely to be in receipt of free school meals. They're disproportionately the poorest and most deprived of our children and indeed of our families. This is EHCPs by ethnicity in England. Travellers of Irish heritage and Black Caribbean pupils have the highest percentage of pupils with an EHCP plan. Indian pupils had the lowest. So again, you know, it's kind of useful to kind of reflect upon your own local situation, but also kind of consider what may be at play here in relation to this over-representation of some ethnic groups. Just in relation to school exclusion, this is permanent exclusions. This is just the trend line for exclusion from school from 2006-7 to 18-19 for England and the southeast. And you can see in the southeast that it is sort of generally falling up to plateauing up to 18-19. I've got the data for each of the ICSs with the local authority footprints kind of within that. But I think this is a kind of interesting slide, particularly if you look at Reading. So I recall in one of the kind of regional meetings, educational psychologist from Reading talking about this very high rate that were experienced within the county, within the local authority, and then actions which were taken, including the introduction of therapeutic thinking in schools to address and reduce that trend. And then that's a great kind of example of preventative intervention, resulting in young people being excluded, building those protective factors available in the educational setting. And I'm sure there was impacts across the whole school population. Just in relation to risk factors, this is permanent exclusions by age in the South East and England. And we see that the highest proportion were in the 14-year-old age group. So that's the kind of prior to that median age of onset of mental health diagnosis that we referred to earlier. So again, kind of gives us that kind of opportunity to sort of intervene. Perhaps building protective factors, maintaining these young people in education will have that impact on mental ill health, or the onset of mental ill health. Permanent exclusions are greater amongst males than females. And there is variation across different ethnic groups. It's pretty hard to really provide much interpretation of this, given these aren't rates. There's no reflection of the kind of size of these ethnic populations, you know, in the Southeast to kind of compare it by. But again, just by eye, Gypsy Roma travellers, other black background, Black Caribbean and white Black Caribbean have higher rates. Moving on to NEET and NET young people. There's two ways in which NEETs are measured. One is through the NEET participation, that's data which is collected by local authorities, and one by the through the labour force survey, which focuses on 16 to 24, and there's another which is the Office for National Statistics. This is the NEET participation rate, so 16 and 17-year-olds across the Southeast, with higher percentages of the population being NEET in Reading, Medway, West Sussex, Kent, Southampton, compared to England. This is the this is labour force survey from the Office for National Statistics, and this shows economic inactivity from, this is January 2019 to January to March 2021, and what we see here is the very stark impact of COVID on the 16 to 24-year-old population. So economic inactivity amongst that group of that population group is at a record high. And there is consistent evidence that this age group have, in terms of children, have suffered significantly from the COVID pandemic. Just kind of ending, looking at vulnerable populations, those young people who are CHIN and children in care. These are the characteristics of children in care. I'm not sure that there is a great deal of evidence to draw from. This is data for England, but there may well be variation to explore in your local populations. I think this is interesting. This is the proportion of assessments of children in care which cites mental health of the child as being a concern. The red indicates where there is a they're significantly worse compared to the southeast. So, you know, that this is about kind of ensuring kind of pathways are right, and that engagement from those young people engaged in our early intervention services, where risks are being identified and preventative interventions being put in place. For children in care, again, their characteristics, this is the southeast region. I think that given that so many of these young people sit within that age bracket, 10 to 16, you know, which again sort of aligns with that medium age of onset, demonstrates what a real opportunity there is to intervene, to you know, support these young people to access treatment if required, but certainly interventions that build their well-being, resilience and well-being. Yeah, there's a real opportunity with that group. And this just kind of gives us again the kind of sense of the age range of that group. Generally, the rate of children in care across the southeast is higher in the Isle of Wight, in Portsmouth, Southampton and Reading. SDQ scores identify children in care for whom there are concerns in relation to their mental health, and here is just you know, analysis sort of showing southeast scores compared to England, and here the fingertip spine showing those local authorities compared to England, where there was a higher percentage of children in care whose emotional well-being was a cause for concern in 2019. Just finally, if we think about children in contact with the youth justice system, just focusing on first-time entrants into the criminal justice system, I mean, colleagues will know that the rate of first-time entrances decreased significantly over a number of years, where there's been policy focused at diverting these young people from the criminal justice system, which is harmful for these young people's emotional and mental health. There is also a metric which is around the number and rate of children cautioned or sentenced per again as a rate against the general population of 10 to 17-year-olds. So I'll leave that for you to look at another time. But it's just kind of worth saying that the likelihood of being sentenced or cautioned increases with age. So we see higher numbers in the 15 to 17-year-old age group than the 10 to 14-year-old, and we see more young men than women. These young people are extraordinarily complex and have been there's a very disproportionate number of them are children in care. These young women, though smaller in number, are understood to be particularly complex, particularly vulnerable, and exposed to multiple adversity. Young offenders or young people involved in the criminal justice system or contact with the criminal justice or youth justice system have higher rates of learning disabilities, neurodevelopmental issues, and there's the rates are strongly correlated to deprivation, and a particular concern around the overrepresentation of minority ethnic communities within this population group. So in summary, children's mental health isn't equally distributed. It's determined by or shaped by age, gender, disability, ethnicity, as well as other protected factors. And it shapes the way that protective factors, impact on risk, and protective factors, including deprivation. These associations are not inevitable, and I think that that's the kind of really important sort of learning. We can work together to do something about this. We have the tools, we have evidence, we have knowledge from our clinicians, and most importantly, I think, and Andrew referred to this, we have the voices of children and young people, and we can use all of this intelligence to assess the need, to ensure that young people who need our help most access services, that they have good experiences and outcomes of those services.
Thank you so much, Jo. We really appreciate the time and energy that's gone in to building this dialogue for us and this analysis for us. There's a lot of dialogue in the chat, Jo, about what we might describe as our children with these additional complexities, and thinking about what might our multidisciplinary response to these children be. Well, many of us are very much focused on children in care because of our regional work and have quite detailed analysis of our children in care's emotional mental health needs, and the intersectionality then with our neurodiverse LD and SEN cohort, our young offending cohort, etc., is really, really important. So as we design these complex children's new services or new ways of delivering in advance of local transformation planning across many of our areas in the South East, this is key intelligence to factor in. There's also some reflections on the importance of therapeutic thinking schools and how helpful that's been in terms of reducing exclusions. We will come back to some of the points raised about actually those areas that are demonstrating higher rates of emotional mental health need may just be identifying better, Jo, maybe asking the right questions, particularly of those children with greater complexity who may find it harder to trust our services. So in terms of specific questions, we will respond to the request about the yacht services and first-time entrants and good examples there. In terms of exclusions, Jo, there's a question to say, could we standardise across our population permanent exclusion rates? Can we build a kind of a standardised picture of that? And I don't know if you wanted to respond to that.
Yeah, I mean, I'd be really interested in kind of exploring that further. There is quite a lot of sort of additional data around the reason for these exclusions. It might be that, and I don't know who's kind of asking this question, but clearly, I mean, I'm just giving you a kind of a flavour. Your public health teams and your educational departments will be undertaking that analysis. So it may well be that that kind of exists within local authorities, and we just need to kind of think about that at a sort of a southeast, aggregating at southeast level, or taking and sharing the best analysis that's available.
Yes, and it certainly does in the heads of education pans out these conversations, so we could draw on that, Jo, couldn't we, together? So colleagues, we've tried to cram quite a lot into an hour. Our huge thanks to Jo for all your work on this. We really appreciate it. These slides will follow, the recording will follow alongside a frequently asked questions document, which we'll work on with colleagues, including Health and Justice and our LD, SEND colleagues too. And I encourage you to take this back in your partnership conversations to your partnership steering groups, the people co-designing your local transformation planning, designing and delivering emotional mental health services. Do talk to this to public health colleagues who are leading your needs analysis about some of these findings and where you've got more granularity locally. Let's also not forget the importance of just talking to children and young people and understanding their experience. and talking to our leaders in voluntary, in community and in faith sector settings, who will give us a different perspective on this and could be crucial in terms of early identification, early intervention, and our preventative agenda in partnership together. Thank you so much for your time, and if there are any further questions, please don't hesitate to email us. Jo, a very great appreciation to you for all your work on this in particular. Thank you, everybody, and take care.
Thanks very much.
Thank you.
Anna Maria, we can stop the recording. Thank you. Jo, thank you so much for your time and your input. We've really, really appreciated it. Thank you.
That's
wonderful.
Looks like there's some interesting kind of responses. So it kind of worked in terms of getting people thinking, didn't it?
Indeed, thank you so much. So we'll collect the questions and we'll come back with Trish and with Peter Gates to provide a kind of comprehensive response to that. Thank you, Jo.
Cool, no worries. Take care.
Bye.